Medurstand Understanding Medicine.
I'm Professor Aziz Rehman from Medurstand-Understanding Medicine. Today we're going to talk about interpretation of kidney function tests. Of course, when we go through different kidney diseases, we'll be talking about these tests in more details, especially when we talk about kidney failure. So we'll be discussing these tests in much more detail, but this is just an outline to let you know what are the basic tests we perform in kidney diseases and how do we interpret them. So this is the list. Urine complete examination, of course, very simple test. Then urine osmolality and specific gravity, serum creatinine, blood urea and blood urea nitrogen. GFR can be calculated and eGFR can be derived from a formula. Serum electrolytes and arterial blood gases, and if especially patient has got kidney failure, then serum calcium, phosphate, alkaline phosphatase, ultrasound and biopsy. Now let me say, actually this is a very brief list of the investigation which we do in kidney disorders. Depending upon which type of kidney disease you are talking about, there would be need for many more tests. Like for example, if you suspect an autoimmune disease, many tests depending upon that condition would be needed. So this is the list, and now I'm going to go through these one by one and give you some more detail. First of all, let's talk about simple urine complete examination. The first test I think is urine complete examination. Best is to take morning sample because that is the concentrated, and sometimes we have to measure specific gravity and osmolality, but I believe any sample can be taken. Now in women, I think this is an important point. In women, urine should not be examined when they are menstruating because there could be contamination of menstrual blood and that could lead to many wrong judgments. So first of all, you could just simply inspect the urine sample. Normally it is amber color and clear, but if the color is changed, there are a number of possibilities. It could become yellow, it could become red, it could become dark, it could become black actually, especially when exposed to sunlight, and it may become opaque, like when there is presence of some crystals and amorphous material and some pus, it could become opaque. So color actually refers to the color and clarity refers to the translucency. So I think you can get good information from just simple inspection. And then simple urine dipstick and microscopy. I think this would complete the urine test. Dipstick, you already know that there is a stick which has got multiple blotting papers on that, and they all have different enzymes and they can detect presence of protein, presence of ketones, presence of glucose, and a lot of other stuff like nitrates. So I think this is very important and very simple, and even patient can do this test. All you have to do is to dip the stick in the test tube and just see the color and match it with the table given on the bottle. And microscopic examination is very important. Depending upon what condition you are suspecting, in urinary tract infection, just the presence of pus cells, and in other diseases, a detailed examination of sediment would be very useful. Pus cells, in a normal healthy person, up to 5 pus cells are present. So more than that would indicate infection. But of course, if you have many red cells also, that would actually indicate hematuria. So in the absence of hematuria, presence of neutrophils simply indicates infection. And glucose should normally not be present in urine, except a rare condition called renal glycosuria, or diabetic patients who are excreting glucose when their glucose goes beyond 180, and also those people, those diabetic who are taking SGLT2 inhibitors. So glucose should normally not be present in a healthy person. Protein, again, with this dipstick method, protein should not be detectable. There is a condition called transient orthostatic proteinuria, so maybe you can pick up in some cases, but actually For that test, you need another test to detect small amount of protein. You need another test. I think I'm going to cover that in the next slide. So microalbumin is the amount of albumin which cannot be picked up with the simple dipstick. It needs specialized tests, and those specialized tests, they pick up abnormal amount of protein, usually albumin, when it is there but not in the range of normal test detection. So in a normal healthy person, up to 30 milligram per 24 hours is normal. At 30 to 300 milligram is called microalbuminuria, and more than 300 milligram is macroalbuminuria. And if somebody has more than 3000 milligram, that is nephrotic range proteinuria. So that of course means that patient has got full-fledged nephrotic syndrome. And sediment, that means the urine is centrifuged and examined under microscope. A careful examination of urinary sediments in the context of autoimmune disease or glomerulonephritis can give you lot of information. And I remember my teacher saying that careful examination of urine is like non-invasive kidney biopsy. So imagine how much information you can get from simple, careful urinary examination of the sediment. And then specialized tests. Of course, the list could go long and long. Like if you suspect some drug intoxication, you could do the test. And there are many tests. So I think that is beyond the scope of this lecture. Now, urine osmolality, sometime, urine becomes sometime dilute, sometime it becomes concentrated. Of course, it stays within a certain range, depending upon your state of hydration. Now, if you have not taken water in sufficient quantities and you have dehydration, then urine should be concentrated. That is a physiological change, because your kidneys are trying to preserve water. And if you've taken a lot of water, more than your body needs, then your kidney must be excreting that extra water and urine would be dilute. But urine osmolality and the specific gravity ranges between it varies between a certain range. In the morning, when you wake up, the first sample is usually concentrated. Why? Because during the night, number one, you are not drinking water. Number two, naturally, at night, urine formation, the volume formation is reduced. This is the natural mechanism to allow good uninterrupted sleep. So morning sample is usually concentrated. So if the morning sample is dilute, that would be an indication of an abnormality. So low osmolality, especially in the morning sample, would indicate excretion of free water. That means it more than what is required to excrete the solutes. It could happen in diabetes insipidus. It can also happen in psychogenic polydipsia, and it could also happen when you have simply taken excessive water intake. So all these conditions, there would be low osmolality. Normally, we do not make a final judgment on just one observation. In the proper context, if you are already suspecting diabetes insipidus or psychogenic polydipsia, a low osmolality in the morning sample may be a sign of this disease. But otherwise, it's just one simple random finding. I think it could be simple excessive water intake. Don't make a diagnosis of diabetes insipidus or psychogenic polydipsia. High specific gravity would indicate a state of dehydration again, and also a presence of proteins and the presence of many other solutes like urates and other things. So a specific gravity, and somebody who just had a procedure like he had intravenous pyelography or some other contrast study, or he had mannitol, that would be excreted in the urine and would lead to increased specific gravity. Now, serum creatinine, blood urea nitrogen, and blood urea I have put in one group because they are usually referred to as renal function tests, RFTs, and they are done together. So the background, creatinine comes from our muscle, and our muscle size varies from person to person, depending upon your body size and also depending upon your gender. Men have more muscle than women, and also ethnicity, like black people, they have more muscle mass, so it could vary. And so whenever you interpret creatinine, you have to consider all these in mind. Uh, Generally speaking, creatinine is considered to be a better indicator of kidney function. Blood urea nitrogen and urea, they can also give you the same information, but they're subject to state of hydration. Slight dehydration can lead to a slight elevation in blood urea nitrogen and urea. Both reflect the same thing. In acute renal shutdown, they may go up, but they do not proportionately reflect the status of kidney, whereas creatinine is definitely better. Although creatinine is also not perfect, but that's definitely better than blood urea nitrogen and urea. So these are convenient first line investigation. Whenever you suspect any kidney disease, anybody who has a metabolic disease where there could be involvement of kidney, for example, you are investigating a patient with diabetes or hypertension or heart failure or autoimmune disease, you would obviously like to know the kidney function, and these are the first line. If they are okay, then you may not proceed further. But if they are abnormal, then you can of course need other tests. You can do the other test. Creatinine is very good for monitoring of chronic stable disease. Now, there are diseases, for example, diabetic nephropathy, hypertensive nephropathy, glomerulonephritis, amyloidosis. In all these conditions, we have to monitor kidney function on long term. So creatinine can provide a good simple test to monitor chronic conditions. In acute setting, it may lag behind. In acute kidney injury, for example, now if somebody has acute renal shutdown, there is many reasons why one could have a acute renal shutdown. In that condition, your GFR may be like very low, but for certain time your creatinine may still be normal, because creatinine increases by 1 milligram a day. So on day 2, kidney function may be 0, but your creatinine may be only 2. So I think in the acute setting, creatinine may not truly reflect the actual situation, but in chronic stable disease, it is a good test. Now, again, another thing, same creatinine for two different individuals could reflect two different situations. Now, this is an example. Somebody having creatinine of 1.9, and if that person is 120 kg man or 20 kg girl, and this could actually indicate very different GFRs, glomerular filtration rate. We actually are more interested in glomerular filtration rate because traditionally glomerular filtration rate measurement has been very tedious and cumbersome, so we have been avoiding this. But these days there is a better way and easy way to calculate them, and so we have now more and more referring to GFR, eGFR. So I think you must consider the proper perspective. Two different person, although the creatinine is the same, 1.9 creatinine in this young girl would indicate very advanced kidney disease, whereas 1.9 creatinine in this big man with muscle could be normal. So now we come to this GFR and eGFR. What is GFR? It is the amount of water filtered through the glomeruli in 1 minute, per minute. So water, of course, plasma, minus proteins and minus cells. It is the amount of free fluid from the blood which enters the Bowman's capsule per minute. All glomeruli together in both sides, 1 minute. So that measures the total glomerular health. So this is the GFR, glomerular filtration rate. As the name says, glomerular. So it has to be the water going through the glomerule, and filtration, the amount of fluid which is filtered into the Bowman and then Bowman's capsule, and that rate. And the rate, of course, is per minute. It's times by time bar. So GFR can be measured with inulin clearance. Now I will have to give you a little background. Please bear with me. We need to measure glomerular filtration rate. We need some substance which, if taken orally, for example, or given intravenously, is not metabolized in the kidneys, in the liver, is filtered through the glomeruli without any obstruction. So all the amount in the plasma goes into the Bowman's capsule, and then in the tubule it is neither reabsorbed nor excreted. So all the substance which is excreted into the Bowman's capsulated pass on into the urine. So if we have that substance, then we measure urine for 24 hours and measure the total amount of that substance excreted in the urine, and we measure the plasma level also. For then we can do the glomerular filtration rate measurement. Now such substance is inulin. Inulin is expensive, not routinely available, not actually routinely done, but this qualifies the substance which can measure GFR truly. But you will have to measure 24-hour urinary inulin and urinary volume, and also plasma inulin level. So very, very cumbersome. Luckily, we have different methods. Creatinine clearance. Creatinine is a natural substance which is present in our body. So you could use creatinine, not the inulin in this case. But creatinine does not actually qualify truly to be this ideal substance. Why? Because creatinine is excreted into the Bowman's capsule. That there creatinine qualifies. But in the tubules, more creatinine is excreted into the tubules, about 10%. So creatinine clearance, if you measure serum creatinine and you measure total amount of creatinine excreted into the urine in 24 hours, it will overestimate GFR by approximately 10%. But that is definitely easier than this because you don't have to use this inulin substance. But then this would still require 24-hour urinary measurement. But I think now life has become easy. We can use these eGFR. eGFR is actually estimated glomerular filtration rate. Now this can be derived from many formulae, and there is a lot of science and physics and chemistry behind these formulae, and I will certainly not going to go into that detail because that will take me beyond the scope of internists. Of course, if you're talking to a nephrologist, they will talk about these formulae in detail and the philosophy behind, but there are many available. You can use any one. They consider patient's age, patient's gender, patient weight, and patient ethnicity. So if you feed in all this, instantly you get the value. I think I would recommend that whatever formula you like, you should use the same, because in one individual, we are actually more interested in following the trend of his kidney function. At one time, of course, when we start the treatment, we are interested to know the kidney function, the status of kidney function. But then during treatment and follow-up, we are more interested in the trend. So use the same formula. If you use different formulae, then I think you will be misled. So you can find these formula online, and these are downloadable apps also. Very interestingly, there is another test called cystatin C clearance. Now, cystatin is a substance which is present like in every individual. Where does it come from? From some food or from metabolism? I don't really know, but this is present in every person, and this can be used as a substitute of creatinine clearance, and you can use this one also. To my understanding, this is not available in our country yet. So I think out of this, you have to measure different things, and eGFR is perhaps the best and the easiest. Now let's talk about serum electrolytes and arterial blood gas. Sodium is very, very important. Sodium is excreted by the kidneys. Normally kidney is trying to preserve sodium because we need sodium, but mostly we're taking sodium more than our requirement, so kidney is allowing sodium also to pass through. But in kidney failure, serum sodium can go low and can go up. And potassium typically goes up in chronic disease. In acute renal failure, in acute renal shutdown, it goes up very fast. Chlorides can also go abnormal. Bicarbonates also can be abnormal. Typically they go low because they indicate acidosis. And magnesium also goes up. And I'm talking about the kidney failure. In acute or chronic kidney failure, these things are abnormal. So we are very much concerned about these. In arterial blood gas, we would know the pH is likely to go in the acidic form because patient depend and develop metabolic acidosis. You know, metabolic acidosis is further of two types. In kidney disease, you could develop of either type. You could develop metabolic acidosis with normal anion gap, or you could develop metabolic acidosis with widened anion gap. So this I've already talked about. Now last, I think we're coming to the end of this presentation. Now serum calcium phosphate and alkaline phosphate. You know, vitamin D, for example, which we ingest, or the vitamin D which is produced in the body with exposure to sun, that is not active. That is converted into in the two stages. First in the liver, second in the kidney. The final form is 1,25 dihydroxycholecalciferol. That is active form, and that is done by the kidney. So I think calcium phosphate and alkaline phosphatase also become very relevant when we talk about kidney disease. Most patients would develop hypocalcemia. Hypercalcemia is also possible. Hypercalcemia can lead to kidney failure, but kidney failure would most likely cause hypocalcemia because vitamin D is not activated, and vitamin D is required to absorb calcium from the gut and also to mobilize it from the bone. So I think hypocalcemia is likely, and hypocalcemia is usually associated with hyperphosphatemia. This is a typical feature of chronic kidney disease. And there may be hypermagnesemia. Magnesium is also an ion which is excreted by the kidneys, and if kidney functions are down, magnesium level is also up. Now magnesium is very relevant because it could precipitate secondary hyperparathyroidism. In the presence of hyperphosphatemia and hypocalcemia, hypermagnesemia would cause secondary hyperparathyroidism. This secondary hyperparathyroidism can cause further kidney damage. So many therapies are actually focused on or targeted on correcting this secondary hyperparathyroidism. The ultrasonography, very simple imaging test. So far we have been talking about the urine test and the blood test, but now the imaging test. Ultrasonography is very convenient, simple test on the bedside, and you can see the kidney size. Both kidneys are almost same size. Of course there could be some variation, but within a certain age, and there's a very smooth nice outline because of the capsule. So you can identify kidney, the typical bean shape, both kidneys very nicely, and you can further see the cortex and the medulla separately. You can see the capsule, and you can see the calyces, you can see the ureter and all that stuff. So in chronic kidney disease, one simple finding is the loss of corticomedullary and corticocapsule contrast. What does that mean? You can very clearly differentiate between the cortex and medulla of kidney. Cortex is usually blackish, medulla is usually whitish, and you can clearly tell the differentiation. Similarly, corticocapsule, the cortex is black and the capsule is white, so you can again tell the difference. But when there is chronic disease, chronic kidney disease characterized by kidney fibrosis, and that becomes also white, so the clear contrast between the cortex and medulla and the cortex and the capsule is lost. Sometimes it becomes even difficult to identify kidney. It's there, but it is so fibrotic that you can't really identify it as kidney. So I think ultrasound is very, very useful. Sometime we get this report from the sonologist, renal parenchymal changes. That mean that will be actually a milder form of this. So renal parenchymal change, that mean that the sonographic features of kidney parenchyma are changed. They would reflect the chronic kidney disease. Of course, they're unlikely to give you a precise diagnosis, but they will tell you that the kidney is not normal. Kidney size disparity. Now, certain disparity is possible in normal people, but if there is a lot of disparity, like for example, one kidney is 1.5 or bigger than the other kidney, that would indicate either renal agenesis, or it could indicate, more importantly, it could indicate renal artery stenosis. Now, if this is a hypertensive patient, this might give you a clue to the diagnosis of renal artery stenosis and provide an opportunity to correct that stenosis and to cure hypertension. Renal cell carcinoma, because one of the malignancies is related to kidney, and that can be diagnosed on simple ultrasound. Renal cell carcinoma, if detected early, provides you the opportunity to remove the kidney and the tumor with very good prognosis, because for a very long time the tumor stays within the capsule. Then renal artery stenosis. There is a scan, a normal ultrasound picks up the kidney size, but there's a type of scan we call duplex scan. With that, the sonologist will measure the flow of blood in the renal artery and also see the renal artery. With that, the person compared one side with the other side, a renal artery stenosis can be diagnosed. Of course, this patient would require an angiogram for the final confirmation, but simple ultrasound can give you the diagnosis of renal artery stenosis. Now finally, biopsy. Biopsy is usually considered a final test in any disease, and in most kidney diseases, biopsy is not needed because we know from the other tests what is the disease, but in some cases, of course, it would be needed and very useful. Only a qualified nephrologist or urologist will be able to do this. There are two types of needle used, true cut and short cut biopsy, and this is usually done under ultrasound. Typically, patient lies on his stomach, and from the back we approach and we take biopsy of the lower pole so that we don't harm the adrenals. So biopsy can be then examined under microscope, under electron microscope, or under immunofluorescent microscope, and based on that, I think we can make a very, very accurate diagnosis with the help of a trained pathologist. So that was all. I think now, to summary, a good history and physical examination is a prerequisite for proper interpretation of laboratory tests in kidney disease. Now this I think should go without saying, but I would like to say it again because it is extremely important. Any lab test can be interpreted only with the proper perspective if you know the history, if you're suspecting something. Then urine complete examination and serum creatinine are the primary tests, and very mostly I think they're sufficient one, and eGFR is best to monitor the course of chronic disease. Mostly we want to know if the kidney functions are stable or going up or going down. And other tests, many tests which are beyond the scope of this lecture, they are done as needed. Thank you very much. This has been Professor Aziz Rehman from Medurstand-Understanding Medicine. I look forward to see you in my next presentation. Thank you.